Thanks for inviting me over, and thank you all for coming today. And I'm always a little hesitant when people mention the genius thing, because then expectations go up for the talk, and then people are inevitably disappointed and leave saying, really, that was it? So please lower any expectations. So I'm here today to talk a little bit about what we think are some recent advances in the understanding and our ability to predict suicidal behavior. And so I'm going to talk for about 60 minutes or so and then leave time for questions. But please, this would be great if it's a dialogue rather than a monologue. So if you have questions throughout, if anything's unclear, please raise your hand, stop me, and we can take questions as we go. So before getting started, I want to take a step back and talk a little bit about why focus on suicide and suicidal behavior. This is a topic, as Dr. Picard mentioned, we wish didn't exist, but it does. But it remains something that people really don't like to talk about, don't like to think about. My wife says, don't talk about this, don't talk about your work at parties. People don't want to hear it. And it's true, they walk away. So why are we here on a nice fall day focusing on this topic? The reason is, this is a problem that has perplexed us as humans since the beginning of time. And since the beginning of recorded history, there has been suicide, there has been self-injury, it's been written about. And for thousands of years, the question of suicide has fallen in the domain of philosophical inquiry. And virtually every major philosopher over the years has written about suicide very eloquently, much more eloquently certainly than I could. But unfortunately, this remains a huge, huge problem. And as Camus I think elegantly articulated, he said there's but one truly serious philosophical problem, and that is suicide. Judging whether or not life is worth living amounts to answering what he calls the fundamental question of philosophy. Again, although people have written about this for a long time, we haven't gained any deeper understanding of why people engage in suicidal behavior. You can see from your faces you don't like philosophy. So let's approach this from a public health perspective. According to the World Health Organization, about 1 million people die by suicide every year, which means one person takes their life somewhere around the globe every 40 seconds. So every minute of every day, another person has died by their own hands. So this is not just a philosophical problem, but a very, very real global problem. There are about 40,000 suicide deaths each year in the US. And this is a little bit of an abstract number if you don't deal in mortality data. To put this in context, this means there are more than 5 times as many suicides as HIV/AIDS-related deaths each year in the US, more than twice as many suicides as homicides. And this last fact is actually true globally. Each year, according to the World Health Organization, around the world, more people die by suicide than all wars, all genocide, all interpersonal violence combined. What you think about it means we're each more likely to die by our own hand than we are by someone else's, which is a really, really staggering statistic. Suicide is the 10th leading cause of all death in the US, 3rd leading cause of death among adolescents and young adults, 2nd leading cause of death behind accidents among college students. So it's a very real problem on college campuses, among high school students, among young adults everywhere. And for this reason, our lab and many others are really interested in trying to understand why risk is so high during this developmental period. And for those who work clinically, I'm a clinical psychologist, and so see patients and train graduate students to do assessments and treatments on patients. So we're really interested in this problem as well, because virtually all clinical psychology Ph.D. students see at least one suicidal patient before even finishing their graduate training. And unfortunately, about a quarter of practicing psychologists and half of psychiatrists will lose a patient to suicide at some point in their career. So again, very big philosophical problem, but not just that, huge problem for us as a society and as educators and as researchers and as clinicians. So given this, what I want to talk about today are, again, some recent advances in understanding, but also our ability to try and predict and prevent these problems. And I want to talk, just given the limited time, about 3 main things. First, I want to talk at trying to better understand who is at risk for suicidal behavior. This is important not just for understanding, but if we want to identify, in the sea of all people in the population, which ones should we really focus on for enhanced screening and prevention efforts, we need to get better at identifying who is most at risk. And what I'll argue for is using findings from epidemiological studies to try and improve our ability to predict suicidal behavior. I also want to talk a little bit about what suicidal thoughts actually look like. Psychology has been a little bit of a weird science historically in that we identify a problem of interest and then go back to our laboratories and devise these somewhat artificial methods for trying to study it. We don't do what people in many other sciences have done historically. That's find a problem of interest and go out into nature and observe it as it happens in real time, in real life. And that's been a huge problem for understanding suicide and self-injury, because these thoughts and behaviors often happen in private. And so what I'll argue for is using real-time monitoring to try and improve our ability to understand and better predict and prevent these problems. And I also want to talk about how we might get better at measuring the suicidal mind. This is another big limitation in the field. People who are thinking about suicide or self-injury often don't want to tell others about their thoughts or feelings or intentions for fear of being intervened upon. And so we've been relying as a field on people's self-report. This is a huge limitation. What I'll argue for here is using findings from psychological science to try and improve our ability to detect and predict suicidal thoughts and behaviors in ways that don't just rely on what a person's telling us. So I'm going to try and spend about 15 minutes on each of these things, and then again leave some time for questions. But again, don't hesitate to interrupt or ask questions if you have them as we go. So first, who's at risk for suicidal behavior? Some of those basic fundamental questions we need to understand in understanding this problem are, how often do suicidal behaviors exist? And I'll talk about suicidal ideation, or having serious thoughts about suicide, suicide plans, formulating a plan to kill yourself, and actually going out and making a suicide attempt. How often do these things occur in our communities is important to understand as a very first step. And we also want to know when they tend to begin, how they change over time, and whether we can identify common risk and protective factors. Really basic, really fundamental questions, but unfortunately ones that we haven't had the answer to, in large part due to the limited way in which we've been studying suicidal behaviors. Most studies that have been done on suicidal behaviors have been done in the West, and the majority in the US. And what we typically do as suicide researchers is get small, somewhat selected samples of people in order to study this problem. So for instance, we'll look at 100 middle school students in New York, or 200 high school students in Boston, or 150 psychiatric inpatients in Texas, and so on. And there are a few problems with this. One is a problem of representativeness. We know that suicide death rates vary pretty dramatically across the US, with actually the lowest rates in the Northeast and in the mid-Atlantic states, and they vary pretty dramatically around the world. And this may be true of suicidal behaviors more generally. It may be that we're limited in the inferences that we can draw with a small sample collected in one place, one geographical place. The results may not generalize. Suicide may look very different in the Northeast United States than it does in Nigeria, than it does in France, and so on. Also, so the problem of representativeness, there's also a problem of small sample size. Although suicide is a leading cause of death, it's a fairly low base rate behavior. And so if you have a sample of 100 people or 500 people, there's not going to be many suicidal people in that sample. And so we can't study this behavior in any kind of fine-grained way. So to try and overcome these problems, our research group, with many collaborators around the world, have been conducting what we think is one of the largest, most representative study of suicidal behaviors ever done. What we're doing is using nationally representative samples of thousands of people in each country that we're looking at. In the US, we're using data from the National Comorbidity Survey done by Ron Kessler and colleagues across the river at Harvard Medical School. And this is a sample of about a nationally representative sample, so essentially randomly selected people, about 10,000 adults in the US. Interviewers go to their home and ask them about 2 hours worth of questions, not just about suicidal thoughts and plans and attempts, but about a range of potential risk and protective factors. So we'll have a large representative sample in the US, and this study has been essentially replicated in about 24 countries across the Americas, Europe, Africa, Asia, and the Pacific. In each country, a nationally representative sample of several thousand people, and these data are analyzed within each country, but also sent back to Ron Kessler's group, to his data coordination center at the medical school for analysis. And this is all done under the auspices of the World Health Organization World Mental Health Survey Initiative. And what I want to present quickly are some early findings on what suicidal behaviors look like in these different countries around the world, pooling all of these data together to give us a really large representative sample. So answering the first question, how prevalent are suicidal thoughts? What percentage of people, adults, 18 plus, say that they've seriously considered suicide at some point in their life? What we find is about 9% of adults say that they've seriously considered suicide at some point in their life. And these are data from the first 17 countries that had data ready for analysis with a sample of about 85,000 people. About 3,000 people make suicide plans, and just under 3% of people say that they've made a suicide attempt. They've attempted to kill themselves. Fairly high rates, I think. You'll also notice, though, that these rates vary pretty dramatically around the globe. About 3% of people in China say they've thought about suicide, compared to about 15% of people in New Zealand and the US. The US is consistently highest. 15% of people in the US say that they've seriously considered killing themselves. 5% have made a plan. 5% have made an attempt. We're trying to understand why this cross-national variability exists. We don't know. It's not explained by geography. It's not explained by what the World Bank classifies as low, middle, high-income countries, developing versus developed. We looked at this a number of ways, and that doesn't explain the cross-national variability. These are self-report data, so that variability, a lot of it might be due to stigma, willingness to report these things in a given country, and so on. Yes?
I have a question about the difference for Italy there on the 0.7 to 0.9. So
yeah.
2/10 of a percent of people in Italy who made the attempt didn't have a plan. So is that more of a spur of the moment?
That's right. So not that's Italian piece. Maybe. But yeah, so I should clarify. So the way this survey works is people are asked, have you ever seriously considered killing yourself? If they say yes, they're asked, did you have a plan? Regardless what they say to plan, they're asked, did you make an attempt? So some people made what we call a planned attempt. They said, yes, I had a plan, and then I made an attempt. Some people have what we call an unplanned attempt, meaning they had ideation and then made an attempt. They said they had no plan. And you could argue about, can you actually make an attempt without a plan? We think of this as sort of, it's more spur of the moment, sort of like premeditated versus unpremeditated homicide. Did you plan it for a long time and then do it, or did you just do it spontaneously? So these so when I show more numbers on plan and attempt, you'll note that some attempts are planned and some are unplanned.
Do you look at kind of the difference between those numbers across countries? Are there more countries that are more spontaneous?
Yeah, we have those data, and we publish those data. I don't recall offhand if there are differences in ratio of planned attempt to unplanned attempt. Consistently, having a plan significantly, hugely increases your odds of subsequent suicide attempt. Yes?
How do you weigh thinking about suicide versus just thinking about being dead?
Mm-hmm.
Because I will often hear people talk about wishing they were dead,
Right.
but they don't want to kill themselves.
That's right.
They have kind of self-injury.
Right. So in the field, many people make a distinction between, I should say as a broader point, as a field, suicide research is pretty, I think, primitive and coarse in how we assess these outcomes. So we ask people, in this study, have you seriously considered killing yourself? In other studies, a person might measure ideation by saying, did you ever wish you were dead? And the prevalence estimates will be much higher because many more people wish they were dead than seriously consider suicide. And we have a graduate student who's, as part of his dissertation research right now, is looking at this in more detail. And what we see is that about 15% of people who say that they have thought about suicide didn't really think about suicide. They thought about wishing they were dead, or maybe I shouldn't be here. So what we call more passive ideation rather than active ideation. And there are lots of other more fine-grained distinctions that people make, like, what does making a plan really mean? Does it mean thinking of a method? Does it mean thinking of a place? Does it mean planning a time? And when people say yes to plan, they're all over the place on those characteristics. What does making an attempt mean? Same thing. About 15% of people who say they've made an attempt, when we ask follow-up questions, didn't really engage in self-injurious behavior with some intention of dying. They started engaging in preparatory behavior, collecting pills, but never actually took them, that kind of thing. So keep those, all these are limitations with how we've been asking these questions. And these data don't take those more subtle distinctions into account. Great questions. So what's interesting, to me at least, is although there's this cross-national variability in the rate of reporting thinking about suicide, once people say they've thought about suicide, suicidal thoughts and behaviors look pretty consistent cross-nationally. They look consistent in age of onset. So this is a cumulative age of onset distribution. Each line represents a different country, and this is risk of thinking about suicide for each year of life among those who do. I would encourage you not to try and figure out which line is which country. When I do this, I get dizzy. But I didn't go to MIT, so you guys are much better than I am at looking at these lines. What I want to note is there's very little thinking about suicide during childhood and then during adolescence and young adulthood. In every country we examine, the risk increases dramatically. It's like a big wave. So every country we look at, there's a little bit more separation later in life, but during adolescence and young adulthood, every country shows this big increase. So something about this earlier developmental period is important for thinking about suicide. We also see consistency in the probability of transitioning from thought to plan and from thought to attempt. In virtually every country we examine, about a third of people who think about suicide transition to making an attempt, which means 2/3 of people who think about suicide never make an attempt. The speed of that transition also is pretty consistent cross-nationally. This figure shows the speed of transition from thought to attempt among those who make that transition. On the x-axis here is number of years since onset of ideation until making an attempt. And what you'll see is in every country we examine, 60% of the time or more that transition happens, it happens in the first year after onset of ideation, which suggests the first year that a person thinking about suicide is a high-risk time for making the transition to an attempt. Not shown here, the longer a person goes thinking about suicide without making an attempt, the less likely they are to make an attempt, which may be counterintuitive. You think if a person's been thinking about suicide for 10 years, they're at really high risk. But if they've been thinking about it for a very long time and have never made an attempt, they've got a decrease in their risk of ever making an attempt. Maybe, we don't know why. Maybe they've got good coping skills. They've got good support network in place. We also see consistency in risk factors. In virtually every country around the world, men are much more likely to die by suicide than women by a ratio of about 4 to 1. But in every country we examined, women are significantly more likely to think about suicide, make a plan, make a non-lethal attempt. Also at higher risk, consistently, are those of younger age, those who are unmarried, either never married, separated, widowed, divorced, and those with a mental disorder. And this is, one can look at this and say, boring, same risk factors in every country. To suicide researchers, this is interesting because there's been a lot of debate about whether the risk factors for suicide are the same in the East versus the West and so on. And these data suggest that when you use the same study design and assessment method, you get very consistent results in terms of what the risk factors are. I'm going to talk a little bit more about mental disorders, given the focus of this seminar, the symposium series, and also because I'm a psychologist and we're really interested in mental disorders as risk factors. So this somewhat busy table, I apologize, shows odds ratios, so increase in the odds. Greater than 1 is an increase, lower than 1 is a decrease, in the subsequent onset of ideation plans and attempts among those with different classes of mental disorders. If I say suicide, which disorder might you think about most often? A mood disorder, like depression. And indeed, we see if you have a mood disorder, the presence of a mood disorder is associated with a 4 to about a 6-fold increase in the odds of thinking about suicide, making a plan, and making an attempt, not surprisingly. What's interesting, though, is we see a similar increase in odds for those with an anxiety disorder, an impulse control disorder like conduct disorder, intermittent explosive disorder, ADHD, a substance use disorder, and in fact, any disorder. If you have any disorder, we see an increase that looks very similar to that for depression. So what's going on here? It's not just depression. It's a number of different disorders, and I'll unpack that in a moment. Below this line, we also see a dose-response relation. So people with exactly only one disorder compared to those with 0 disorder have no increase in their odds. Their odds ratio is not different from 1. If you have 2 disorders compared to those with 0 disorders, we see a doubling in your odds of these outcomes. If you have 3 or more disorders, we see a 6 to 9-fold increase in your odds of these outcomes. So say depression and an anxiety disorder and a substance use disorder. So something about comorbidity, as we call it, or multimorbidity, really increases your risk. Yes?
I'm just wondering if disorders are included and if they're under anxiety disorder or mood disorder.
Eating disorders weren't included here, unfortunately. In mood disorders, it's depression, bipolar disorder, dysthymia. No, not at all. Anxiety, yeah, anxiety is any disorder is any of the disorders assessed. There were 16 assessed. So of the hundreds in the DSM, this study looked at the most prevalent, most common mood disorders, anxiety disorders like panic, agoraphobia, social anxiety, PTSD, and so on. And I'll show some specific disorders in a moment. This slide just tries to summarize it by grouping these together. So again, something about multimorbidity really increases a person's odds or risk of suicidal behavior. Given these somewhat surprising findings to me, we wanted to leverage some of the valuable aspects of the study. We've got thousands of people with ideation, thousands of attempters here, so we can start to look at unique associations between individual mental disorders and subsequent odds of each piece of the pathway to suicide. So in one analysis, we said, we're going to enter all of these disorders at one time, 16 different disorders at one time, as well as comorbidity, number of disorders that you have, to see what is the unique association between each disorder and suicide ideation, thinking about suicide. I'm showing only 4 disorders here for illustrative purposes, but if I put them all in here, you couldn't read the slide. Just as an example, what we see is that each disorder assessed is associated with an increase in your odds of suicidal thoughts. So PTSD, for instance, is associated with about a 50% increase in the odds of suicidal thoughts. The strongest odds ratio is for depression, perhaps not surprisingly. We then said, among those who are thinking about suicide, which disorders predict who acts on their suicidal thoughts? And there, depression does nothing. What does are disorders characterized by anxiety, agitation, poor behavioral control, things like PTSD, conduct disorder, alcohol abuse, and dependence. So putting this together, what may be happening is depression gets a person thinking about suicide but not acting. These other disorders get a person who's thinking about suicide to act on their suicidal thoughts. And this may be why comorbidity and multimorbidity are especially important. And we found this in the US and then replicated it in 21 countries around the world. And we just published a paper this year on suicidal behaviors in the US Army, because rates of suicide in the Army have been skyrocketing. And we see the same pattern of findings, where depression is the strongest risk factor for ideation. Only one disorder predicted which soldiers go on to act on their suicidal thoughts, and that was intermittent explosive disorder, a persistent pattern of impulsive aggressive outburst. So the consistent picture across a number of different studies now seems to be Again, depression, mood disorders get a person thinking about suicide. These other disorders trigger action among those who are having those thoughts. Given we're in a college setting and we see this increased risk among adolescents, I want to focus in a little bit more on this time period. And so we also looked at data, not just from the National Comorbidity Survey, but the National Comorbidity Survey Adolescent Supplement, which is a separate study that collected data from a nationally representative sample of about 10,000 US adolescents. And one criticism that sometimes brought against the National Comorbidity Survey data that we published are, well, these are adults 18 plus reporting back on their age of onset many years ago. So if we look at adolescents, those only up to age 18, we see a very similar pattern of findings. This is onset of ideation, which is virtually absent until adolescence, and plans and attempts also come on once people turn 12, 13 years old. We see these things increase fairly dramatically. In terms of mental disorders that are associated with suicidal thoughts and behaviors, we see a very similar pattern to what we observed in adults. We look at treatment, we see pretty high rates of treatment among adolescents with ideation plans and attempts. And this is a little bit of a good news, bad news kind of slide where about a half to 2/3 of suicidal adolescents were in treatment before their suicidal thoughts or behaviors occurred, which is good news in that we seem to be a fairly good job of either getting people into treatment who are at risk for suicidal thoughts and behaviors, or they're doing a good job of getting themselves into treatment. The less good news is they still went on to think about suicide and to make a suicide attempt. And so I think this is a positive slide or positive finding in that there is an opportunity to help people at risk. We just need to find better ways to do so, to identify those who are in treatment as being at risk, and to take steps to try and predict and prevent this behavior. We've also looked at, given this data set is very large and very rich, a range of different risk and protective factors. I won't go into detail on these, but we've looked at the importance of negative life events, chronic medical conditions, family history of mental disorders. Interesting picture there emerges where if your parents have a history of depression or generalized anxiety disorder, which is often comorbid with depression, worrying, rumination, this predicts you having suicidal thoughts. If your parents have a history of panic, antisocial behavior, high autonomic arousal, this predicts you acting on your suicidal thoughts, which is, I think, pretty consistent and interesting with the pattern that emerged with depression and other disorders. And we have a number of papers reporting these findings, and if you're interested, definitely email me and I can send you these papers, or they're available on our website, and I can go into more. Those papers go into more detail. I wanted to move on, though, and talk about what do we do with these findings. So we've been trying to identify risk factors and protective factors for suicidal thoughts and attempts, but how do we use this information? How do we translate it in a way that can help with prediction? And so our work and that of other groups has turned towards trying to use this information. How do we combine this information and use it to improve prediction? And so in an early study, we attempted to do this in a really fairly crude way, but it's a start. We took our strongest risk factors for suicide attempt among those with ideation, because we thought, well, what do clinicians really need? What would be helpful to clinicians? If you have a patient coming into your office who's thinking about suicide, you really want to know who's going to act on their suicidal thoughts, and that's where we can, I think, have a lot of a bang for our buck in terms of intervening. So among those who are thinking about suicide, what predicts who makes an attempt in the next 12-month period? And so we here used data from the National Comorbidity Survey and took our strongest risk factors. The strongest predictor of attempts is a prior attempt, so that's a big one. And we took our 11 other leading risk factors, and we simply added them up to get a risk score for each person. So crudely, if you had 0 to 3, you're at low risk. If you have 4 to 6, you're at moderate risk, and so on. Really, really simple. And what we found was, in this sample, about 19% of people were classified as being at very low risk, and none of them made a suicide attempt over the 12-month period we examined. About half of people were considered to be at low risk. They had a few of these risk factors, and about 3% of them made a suicide attempt over this 12-month period. 16% of people were intermediate risk, 20% made an attempt. Only 13% of people were considered to be at high risk. They had a lot of these risk factors. 78% made an attempt during this period, and they accounted for 2/3 of all attempts, which suggests that if we just add up risk factors, if we had an index, a measure that asked for some key risk factors among those who are thinking about suicide, we can identify a group of people who are at pretty high risk. This is still going to be a large percentage of people, and we're going to have a lot of false positives, so this is an early, limited approach, but just an illustration that just by taking making simple use of the risk factors that we already know about, we can try and improve our prediction. Yes?
So I've heard statistics several times before that says 95% of suicide survivors come out of tough again. So why does it prey
right? So most people who make a suicide attempt won't die by suicide. 40% of people who die by suicide had made a prior attempt. About 60% of people who die by suicide had not made a prior attempt. So making an attempt is a significant risk factor for subsequent suicide attempts and for subsequent death, but you have a lot of false positives because most people who make a suicide attempt don't go on to die by suicide. And that's the case with a lot of our risk factors. Depression. Depression is a very strong risk factor for suicidal ideation, but most people with depression don't go on to think about suicide, make a suicide attempt. So if we just use these risk factors or pile them up, we'll get closer and closer, but we'll still have a lot of false positives. And this is the trick of trying to predict suicidal behavior. It's a very low base rate. Our most accurate model is going to say nobody's going to make a suicide attempt, nobody's going to die by suicide, and that'll give us pretty good accuracy. The trouble is predicting accurately who is going to make a suicide attempt. And so using one risk factor like prior attempt isn't going to get us there. We've got to combine these risk factors. And the trick is, how do we combine them? What's the optimal synthesis or combination strategy? Using this simple additive approach, we did this in the US and then looked at this cross-nationally and had pretty good results across 21 different countries with area under the receiver operating curve about 0.74 to 0.8 cross-nationally. And since then, we've been using more sophisticated predictive modeling approaches, looking at healthcare data to see if we look at a person's medical record, can we get better at using the information that's lying dormant to improve our ability to predict who's at risk for suicidal behavior. We have a paper coming out tomorrow showing that we can get pretty good at identifying 5% of soldiers who represent about 50% of the people who die by suicide in the next year. So the trick is, can we get smaller and smaller concentrations of risk? Or we have, if we're looking for needles in the haystack, can we find those pockets that have a lot of the needles and intervene there? We're still going to have a lot of false positives, but we need to try and use all available methods to get a smaller and smaller group at higher and higher risk if we're going to have any impact. I want to move on to talking about, in the interest of time, what suicidal thoughts actually look like. And now, a problem in the way that we assess suicidal thoughts and self-injurious thoughts is these are transient thoughts and behaviors, we think. They're often not present when we're doing an assessment, and so we rely on a person's long-term retrospective report. We ask people questions like, just like in the data I was just showing, in your life, have you thought of suicide? In your life, have you made a suicide attempt? What was happening at that time? It's a really limited way to measure something. If I asked you, even in an emotionally salient event in your life, your first kiss or the first time you got injured in some way, what was happening at the time? What were you thinking and feeling? You can say something, but a lot of it is going to be based on your reconstruction of memory, and you probably won't give a very accurate recall of what happened at the time of the event. And this is a limitation that's plagued the suicide research field, in that we don't observe these behaviors as they actually happen. As a result, basic characteristics of self-injurious thoughts and behaviors, I abbreviate here SITB, as they naturally occur, are not known. Things like, among those who have self-injurious thoughts, how often do those thoughts occur? How long do they last? Is it 5 minutes? Is it 5 hours? We just don't know. In what context do they typically occur? What predicts in real time whether a thought's going to lead to a behavior or not? Again, really, really basic questions, but we haven't had the answers because we haven't gone out into the world and observed people with self-injurious thoughts and behaviors. And the trick is, we'd want to bring them into the lab and study them in the lab, but people often don't have self-injurious thoughts when they're in the lab, and we can't ethically induce them like we can with mood, depression, or anxiety. Lots of studies in psychology. If we want to study depression, we bring people in and we play Russia under the Mongolian yoke at half speed, which if you listen to it or participate in a psychology experiment, people get really sad, and then we can study what sad mood is like. Or if you're spider phobic, we have tarantulas in the lab, we bring you in, we expose you to spiders, and people get freaked out, and we can study anxiety in real time. We can't ethically do that. We can't induce thoughts of self-injury or suicide. So we want to go out into the world and capture these, but how do we do that? We haven't had the technology to do that. But now, thanks in large part to people here, we do. So our group and other groups have started to try to do real-time monitoring of self-injurious thoughts and behaviors. And what we want to do is examine the natural occurrence of, more broadly, self-destructive thoughts and behaviors as they're happening in real time, using, so far, electronic diary assessments. And so our basic questions are these. First, is this possible? If we give self-injurious adolescents, in this case, electronic diaries, this is a group characterized by emotional and behavioral discontrol, will they bring our electronic diaries back? And will they be in one piece, and will they have information on them? So is this even feasible, was the first question that we had and that our funders had, the American Foundation for Suicide Prevention in this case. If so, if we were able to get some kind of information, what can we learn about just the basic characteristics of self-injurious thoughts and behaviors? What's their frequency, their intensity, their duration, and so on? In what context do they most often occur? And key question throughout our research is what predicts the transition from thought to action, given that most people who think about these things will not act on them? And what's the function of these behaviors? Why do people engage in self-injury? And in this study, we recruited a sample of people, of adolescents, who had engaged in recent non-suicidal self-injury. Non-suicidal self-injury, direct, deliberate destruction of body tissue in the absence of any intent to die, often taking the form of cutting or burning of the skin. Self-injury often co-occurs with suicidal thoughts and behaviors, but we recruited this sample because we wanted to learn a lot about self-injury as well as suicide. So here are some of the characteristics of the sample. And what we did was bring them into our lab at Harvard and train them in how to use an electronic diary. This is a few years back, so they were these Palm Pilots with the little stylus, with the little click boxes, not as fancy as things we have today. They had some software that we gave them, a little disk that they brought home, put on their computer, and their Palm Pilot had a little cradle that they used to collect data twice a day. So the Palm Pilot beeped twice a day, once in the morning, once in the evening, and they recorded whether they had any self-destructive thoughts or behaviors. They also self-initiated any entries whenever they had spontaneously a self-injurious thought and behavior. They did this for 14 days, uploading data each day to a secure server that we monitored. And we tracked it to make sure no one was engaging in anything that was too dangerous. And we had thresholds in place for intervening if anyone was having serious thoughts about killing themselves and so on, which we did have to do in a few instances. And so we just followed this high-risk sample over about a 2-week period to see what we can observe about self-injurious thoughts and behaviors. And the diary structure looked like this. They had either an event log they completed a few times during the day, and they had a nighttime log they completed at the end of each day. In the event log, they were asked about whether they had any self-destructive thoughts, and this is just a sample of what the screen looked like. They were asked whether they had any thoughts of self-injury or suicide. After that, they were asked about a range of other self-destructive thoughts. Did you use alcohol, drugs? Did you binge? Did you purge? And so on. We want to study the extent to which these different behaviors co-occur. We think they might serve, maybe different forms of behavior that might serve the same function, emotion regulation, communication, and so on. If you had the thought, we asked about characteristics of the thought. How intense was it? How long did it last? Who were you with? What were you doing? What were you feeling? What was the context? Did you engage in the behavior? If so, why? What was the function of the behavior? Was it for, and we look at both automatic or internal functions. Did you do it for emotion regulation or external or social or interpersonal functions? Did you do it to communicate or to influence your environment in some way? If you thought about the behavior but didn't do it, what did you do instead? What we often, as psychologists and as mental health professionals, we think we know what will work best for people who are engaging in a behavior. In reality, I think we don't know because we can't prevent these behaviors. So let's see what people are doing naturally to not engage in the behavior, and maybe therein will lie an effective intervention. And so we ask these basic questions, and in our analyses, we also look to see if there are any characteristics or contextual features that predict the transition from thought to action. And so what I want to do is just show some descriptive statistics on what we observed in this small sample over this short period of time. So in terms of feasibility, it worked in that people completed entries and brought the electronic diaries back, and about 83% of folks were fully compliant, that they completed at least 2 entries per day. I should say they were paid $100 for their participation, and if they had over 80% completion rate, they got to keep the Palm Pilot. So there was some incentive for doing this. And this was when Palm Pilots had just come out, so it was very novel, and so kids were really into it. And on average, we had about 40 entries per person, so about 3 per day. So people were doing this pretty frequently. We're happy to learn. This is what we captured. This is non-suicidal self-injury. We had over 300 self-injurious thoughts, about 100 self-injurious behaviors. Interestingly to me, like with suicide, about a third of the time people think about it, they act on it. During about a third of thoughts that people actually engage in self-injury. 26 thoughts of suicide were captured. No suicide attempts, so we can't look at transition from suicidal thought to attempt. And you see here a range of other thoughts and behaviors, about 1,200 different thoughts and behaviors that we captured over this time. I'm going to focus primarily on non-suicidal self-injury and on suicidal thoughts. So who had them? Not surprisingly, because this is a self-injurious sample, Most people had thoughts of non-suicidal self-injury. About a third had thoughts of suicide. You see the range here. And on average, these folks had about one thought of self-injury per day and about one thought of suicide per week, to give us a sense of how frequently these things occur among this group. How severe were the thoughts? How intense was the thought? On average, thoughts of self-injury are of moderate severity. Suicidal thoughts tend to be a little bit more mild, perhaps not surprisingly. And we see for self-injury that greater intensity of thought is associated with greater odds of acting on those thoughts. Not surprisingly, the more intense your thought to engage in self-injury, the more likely you are to engage in the behavior. How long did the thoughts last? Self-injurious thoughts tended to last about 1 to 30 minutes. Sometimes they were very brief. Suicidal thoughts were a little bit longer in duration, so more mild, longer duration. And interestingly, shorter duration of thought predicted engagement in self-injury. And this is probably because if you're thinking about engaging in self-injury and you do, that ceases a thought, whereas if you don't, the thought lingers for longer. So that may be why we see shorter duration predicting the behavior. What were you doing when you had a thought of self-injury or suicide? These adolescents were doing things that adolescents do. They were socializing, resting, listening to music. Not so interesting. What I think is most interesting here is the last two. Substance use, alcohol use are often comorbid with self-injury, with suicidal behavior. But what these data suggest is the very small minority of the time that these thoughts are coming on are people drinking or using drugs. So it's not that they're drinking, they're using drugs, and thinking about self-injury or suicide. They're having these thoughts while sober, the vast majority of the time. What were you feeling? This is what people were feeling when they had a thought of self-injury. Not surprisingly, they were sad, they were overwhelmed, and so on. Interestingly, 4 of these feelings predicted engagement in self-injury. It wasn't sadness, it was feeling angry, feeling self-hatred, feeling rejection or numbness, not sadness. And to me, this is similar to what we see for suicide, where it's depression gets you thinking about it but not acting. It's these more activated, motivated states that get a person acting on their self-injurious thoughts. And for suicidal thoughts, what were we feeling at the time? We see just a high rate of a range of different feelings. And again, we couldn't look at transition to attempt because we didn't have any attempts in the sample. Why, if you hurt yourself, if you engage in self-injury, why did you do that? About 65% of episodes were to get rid of a bad thought or feeling, what we call automatic negative reinforcement, to get to stop having some aversive internal state. And that's the one that gets talked about and studied a lot in the literature. People engage in self-injury, and it somehow, we don't understand the mechanism, ends this internal emotional state. About 25% of the time, though, people engage in self-injury for feeling generation, or as we call it, automatic positive reinforcement. I did not feel anything, and I cut myself for self-stimulation, to feel alive, just to feel something. A smaller percentage of the time was it for social reasons, social negative reinforcement or social positive reinforcement, to escape from people, to get people to leave me alone, to get out of having to do something, or to communicate with someone else, to let them know how much distress I'm in. That's the one that I think the public talks about a lot. People are just doing this for attention or to control someone else's behavior. But people report this is a very small percentage of the time are they doing it often to elicit help or to communicate how much distress they're in. These are all based on self-report. So again, we don't understand the mechanisms through which self-injury might decrease a person's negative thoughts or feelings. And we've since started using real-time physiological data collection using the LifeShirt, which came out several years ago, and I know there are newer technologies that can do this, but we're trying to measure what's happening physiologically before, during, and after episodes of self-injury. Again, we can't bring people into the lab and have them hurt themselves, but with advances in technology, we can have people wear a small laboratory, go out into the world, hit a button whenever they engage in self-injury, which will stamp the data, and we can look at the 15 minutes before and the 30 minutes after to see what's happening physiologically. And we do see increases in arousal before self-injury and a relaxation response or a decrease in arousal right after a person engages in self-injury. And so we're trying to, again, take advances in technology to better capture these behaviors as they're occurring so we can better understand them, better predict them, and try and better prevent them. If you thought about self-injury but didn't engage in the behavior, what did you do instead? And people reported engaging in a range of other behaviors. I ate, which I thought was great, but I have colleagues who study eating disorders who were less excited about that. And people did a range of things to try and change their thoughts. A lot of this we can think of as distraction or distress tolerance. And people, self-reported. They wrote in a number of different things that they do when they think about self-injury instead of engaging in the behavior. I exercised, I held my puppy, I took a shower, Hopefully not all at the same time, but a range of different things to try and perhaps calm myself down or distract myself. Exercise was one that we saw a lot. People reported a lot that they engaged in exercise when they thought about self-injury, and they went on to not engage in the behavior. So we wanted to test this out. Is exercise a simple intervention? Is it potentially a way to decrease the likelihood that a person engages in self-injury? So we had a senior for his Harvard senior thesis who was interested in testing this out. For a senior thesis, it's tough to do a large-scale randomized clinical trial. But there are other ways of experimentally testing whether an intervention is effective. And one way is using a single case experimental design. I don't know if people use these around this campus. In psychology, it's a sort of forgotten art or forgotten science of testing causal effects of an intervention. Essentially, for those who's familiar with single case experiments? Okay, great. For everyone else, so the idea in testing an experiment is you assign some people to one condition, usually in between groups design. Half of you will get the treatment, half of you will get no treatment, and we'll see if people who got treatment have a decrease in the target behavior. A more efficient way to do this is to take one person and assign them to the control condition, no treatment, now they get treatment. Now they get no treatment, now they get treatment, which is one type of single case experiment. So we can see within a person, does the behavior decrease when and only when they get the intervention? That's called an A-B design or a withdrawal design because you apply, then withdraw the intervention. There are lots of variations on this theme that don't require removing an effective intervention for ethical reasons. For those interested in learning more about single case experiments, my colleagues and I have a book creatively called Single Case Experimental Designs, written by Dave Barlow, Michelle Herson, and myself. I'm sure these days, so conflict of interest, I'm a co-author on the book, but I'm sure these days it's on Google Books or somewhere you can get it for free. We have articles on this as well, so I'm not trying to influence you to buy the book. If you are interested in this topic, I would encourage you to check out these designs. What's nice is they can be used by anyone. So this is a senior thesis who tested whether an exercise intervention was effective for self-injury. So this is a study done by Matt Wallenstein, who now is I think, pediatrician at Stanford. This is a few years since we published this. We had a middle-aged woman, who was engaging in self-injury fairly frequently. And so we just tracked over a period of 12 weeks, how many times a week was she engaging in self-injury. And so during the baseline period, we see she was cutting herself 2 or 3 times a week. And I should note, she was in an intensive therapy called dialectical behavior therapy, about 4 hours a day, 5 days a week, still engaging in fairly frequent self-injury. We collected data for a few weeks to get a stable baseline and then assigned her to an aerobic exercise intervention. We gave her an aerobic exercise tape, or DVD, to do 3 times a week and in response to any urge to engage in self-injury. And we saw a pretty substantial decrease in self-injury. She then returned to baseline, no exercise tape. Self-injury was up. We then reassigned her to the intervention. Self-injury came down and was at 0 throughout the rest of the study period. So it's one person, pretty, I think, nice result. We don't replicate this across a second person and a third person and a fourth person. The knock on single case experiments is it's only one person. Right, but you can replicate it across 2 or 3 or 5 people to see do you consistently get this pattern of results. What's nice also is if not, you assign the person to exercise, they stay flat, you can assign the baseline and then do a different intervention, putting ice cubes on the skin or using something else that a person might do to try and decrease engagement in self-injury. But very flexible design that can be used to test out interventions that people, if you're working in a counseling center, at student services, you can test out different interventions to see what's effective. I think we need more of this because there is currently no evidence-based treatment for self-injury, and so we need more, I think, creative experimenting with newer interventions. With that, I wanted to transition to talking about how we might better measure the suicidal mind. Now, a big problem here, and this is another great challenge in suicide and self-injury research, is that current ways of assessing whether a person is thinking about self-injury or suicide rely on asking them, are you thinking about self-injury? Are you thinking about suicide? This is limited for reasons that are probably obvious. One is that many people who are thinking about self-injury or suicide have a motivation to deny or conceal these thoughts for fear of being intervened upon or fear of being hospitalized. Essentially, as a field, if a person tells us, I'm seriously considered killing myself and I plan to kill myself, we often involuntarily admit them to a psychiatric hospital, hold them, not always, but in extreme cases, hold them there until they convince us that they're no longer thinking about suicide or no longer at risk, and then we let them out of the hospital. And so people have just a natural, obvious motivation to not tell us exactly what they're thinking if they think that we're going to respond in a way that they don't like. I wouldn't say that all or most suicidal people or self-injurious people are dishonest. There is a motivation to deny or conceal these thoughts, but we also know from our real-time monitoring data, these thoughts are transient in nature. They're there, then they're gone. And they may be absent upon assessment, only to return weeks or days or hours or minutes later. Also, people may lack conscious awareness of their level of risk or just may not be able to report it. And this is especially a concern among children and adolescents who may not have the words or the assertiveness or the desire to tell us what they're thinking. We may not have the awareness of what their level of risk is, when we know from decades of research in psychology that people are not always able to report accurately on factors influencing their behavior. We know that these are problematic, and there are data to support this. One of the highest risk times for suicide death is the week after people leave a hospital. So people are leaving a hospital, and then the suicide death rate spikes in the week after, the 2 weeks after they leave the hospital. Presumably, clinicians aren't letting people go knowing they're at high risk, and people may not know they're high risk, but we know that this is a high risk period. We know we need to get better at assessing people's imminent risk. We also know that nearly 80% of people who die by suicide in the hospital explicitly denied suicidal thoughts or intentions in their last assessment before dying. So clinicians, nurses are going around asking people in the hospital if they're thinking about suicide. People say no, and then shortly thereafter often die by suicide. So we need a method of assessing self-injurious and suicidal thoughts that doesn't rely on a person's self-report. So for those who think visually like I do, we have a person in front of us in the research lab or in the clinic or in our dorm room who's telling us, I don't want to kill myself. What we really want to know is, how is that person thinking about self-injury or suicide? What are their unspoken thoughts or their implicit cognitions? Implicit cognitions are those that aren't reliant on conscious introspection or explicit self-report. And we've always, I think, since the beginning of time, wanted to know what a person is telling us, what a person is not telling us. What are they thinking and not telling us? We want to know what our significant other, our parents, our friends, what are they thinking that they may not be telling me? And we haven't had the methods to access the content of people's thoughts or how they're thinking about different things until fairly recently. And social and cognitive psychologists and others have developed methods of measuring implicit cognition using tests of things like memory and reaction time and other forms of behavior. One method of doing this is, to give an example, the implicit association test, or IAT, developed by Tony Greenwald and colleagues about 15 or so years ago. Who knows of the IAT? Okay, so just a few people. This is a brief, computer-based, about 5-minute test, reaction time test that shows different stimuli on the screen, asks you to classify these stimuli, and uses the speed of your classification to measure the strength of association you hold between different concepts and attributes. So for instance, this is developed, Tony Greenwald is a social psychologist, and this test has been developed and used primarily by social psychologists to measure things like, how do you think about people of different races or ages or genders or political orientation? So for instance, a popular IAT measures how you think about Democrats versus Republicans, and it goes like this. So you're seated at a computer screen with one finger on, I'll try and do this reversed, a left key, the E key, and one finger on the I key, which is on the right. So you've got left and right. And I'm going to show you on the screen pictures of Bill Clinton and George Bush, randomly on the screen, one at a time. And I'm going to show you good words, strong, smart, leader, and bad words, stupid, coward, liar. And what I want you to do is hit the left key for any Bill Clinton image or good word. Hit the right key for any George Bush image or bad word. Go as fast as you can without making any mistakes, and you go for 40 trials. Now we'll flip it. Now hit the left key for George Bush and good, and the right key for Bill Clinton and bad. And you go as fast as you can without making any mistakes. And these are counterbalanced across people. What we find, or what social psychologists find, is if you're a Democrat, you're significantly faster in milliseconds hitting a key if Bill Clinton and good are paired to the same key. If you're a Democrat, you've got to hit the same button for George Bush and good. It takes just a little bit longer to do that because you associate these things as not being the same. It's like if we did, jockeys, basketball players, tall and short. One classification you go fast, the other just a little bit harder to do. And it's a nonpartisan test. The opposite is true as well. If you're a Republican, it's harder and it takes you longer to hit the same key for Bill Clinton and good because you don't associate these things as being like each other. So a really simple test of association with pretty robust results. It has been shown to be pretty reliable and resistant to attempts to fake good. So if you respond too quickly or too slowly, those trials get thrown out. So if you're a Democrat, it's kind of hard, not impossible, but kind of hard to look like a Republican and vice versa. It's been shown to be pretty sensitive to change over the course of treatment. Bethany Teachman, who's now at University of Virginia, showed if you treat spider phobics, who I mentioned earlier. So psychologists do a lot of studies with spider phobics, not because spider phobia is some big plague to our society, but because it's easy to study anxiety in spider phobics. You can pretty easily induce anxiety and treat it and observe the effects, so we can learn about anxiety more broadly. So that's why I'm referring to spider phobia. But Bethany did a study where she had spider phobics, gave them exposure therapy. So at the beginning, they were afraid to go near a spider tank. By the end, they can put spiders on their heads and stuff. They were, essentially cured of their spider phobia. Their implicit associations about the dangers of spiders changed. So that their performance on this test, their speed of the reaction time changed over time, which is a really nice feature of the test. And it's been shown largely in social psych studies to predict future behavior, voting behavior, and so on. What we wondered is, can we use this test, same structure of the test, but change the content to measure how people think about self-injury and suicide? And so we took the same test, swapped out the stimuli we wanted to assess. So we had, instead of George Bush, Bill Clinton, cutting and no cutting to represent self-injury and non-injury. And instead of good or bad, we did a good and bad version, but we also did a me, not me version. Is it like me or is it not like me? Stimuli appear in the center of the screen, and in this case, we showed cut skin. So you'd hit the left key for this one. Left key, because that's a me word. Right key, and so on for 40 trials. Now we switch it. Now cutting is paired with not me, and we do the same thing for 40 trials. And what we think is, if you are somebody who engages in self-injury, you should be faster responding when cutting and me are paired. If you are a non-injurer, you should be faster when cutting and not me are paired. And what we do is calculate for each person a D score, which is like a Cohen's D score, a standardized difference score. So essentially, we take your response latency when cutting and not me are paired, subtract from it your response latency when cutting and me are paired, divided by the standard deviation of all response latencies. So your scores are compared to your scores, so we can compare people who are hypomanic with people who are depressed and so on. And the way we calculate a score is you get a positive score if you're faster responding, or presumably have a stronger association between cutting and me. So when cutting and me are paired together, if you're faster for that condition, you get a positive score. If you're faster responding when cutting and not me are paired, you get a negative score. So we would expect self-injurers to have positive scores, non-injurers to have negative scores. So in an initial study, this is work done with Mahzrin Banaji, who's one of the developers of the IAT, who's in our department at Harvard. We administered this test to a sample of adolescents and young adults with a recent history of self-injury and an age, sex, ethnicity, IQ matched sample of people who did not have a history of self-injury. And what we see is a pretty striking difference between the two groups, with those with a history of non-suicidal self-injury having a positive D-score, those with no such history having a negative D-score, which I see is leading many of you to say, big deal, Nock. We know by their self-report that these two groups differ from each other, and that's a fair critique. I'm glad you made it. This is a little bit of a, I'll say it's a little bit of a big deal. It's a step in the right direction that this is what we're doing now in psychology and psychiatry, trying to identify biomarkers or behavioral markers, objective tests that can help us differentiate between groups. Okay. Reviewers also were as unimpressed as you are. So we did a follow-up study where we said, can this test distinguish between suicide groups, those who have not thought about suicide, those who are currently thinking about suicide, and those who had recently made a suicide attempt? And there we saw even striking differences in our initial study, non-suicidal ideators and then recent attempters. The big question, though, is can this test improve prediction at all? So we know from the earlier epidemiologic data that I presented that things like age, sex, ethnicity, accumulation of mental disorders all predict ideation and attempts. This is nice to show in the lab, but does it add anything to prediction? So we followed everyone in this first lab study for 6 months, called them 6 months later to ask, did they think about suicide? Did they make a suicide attempt within the 6 months after leaving the lab? Well, we first tested baseline incremental predictive validity and found that scores on this test did improve the classification of who is an ideator and who is an attempter. The big question is, can we improve prospective prediction? And we could for suicide ideation. So the performance on this test added incrementally to the prediction of who thought about suicide over the next 6 months. The big test is, can we predict who makes an attempt over the next 6 months? Fortunately, clinically, unfortunately for statistical prediction, only 2 people made a suicide attempt in this first sample over the next 6 months. And these are the output for scores, these are potentially D scores on this self-injury IAT. You see there's one outlier, subject 25. This is the first person to make a suicide attempt. One other person made a suicide attempt who had a high D score. Those 2 scored significantly higher than everyone else, but with only 2 people, we can't really test the incremental predictive validity. but we were encouraged by the findings. And so this led to a grant that we got from the National Institute of Mental Health to go where there are more suicidal people, and so where we can expect more prospective suicide attempts, the emergency room at Mass General Hospital. So we set up shop there with laptops with the IAT, a suicide version of the IAT on it. Same as what I just showed you, but we swapped out, instead of cutting, no cutting, it's death and life were our categories. And instead of pictures of self-injury, we use words like die, death, funeral, and so on. And so we tested people as they came through the emergency room. So we had research assistants set up there with laptops. As people came in, they told us whether they had cut, or they told us and clinicians told us whether they had just come in for a suicide attempt. Everyone who agreed to participate took the IAT, and we tested, can this IAT distinguish between those groups, those who came in for an attempt and those who came in under psychiatric distress but had not made an attempt? And then can this test improve our prediction of who makes an attempt after they leave the hospital? And what we found was that the test does distinguish attempters from non-attempters, and it does distinguish attempters beyond all other factors. So at baseline can improve the statistical prediction of who's a suicide attempter. The big test, yes?
But that's post the attempt.
That's right.
Maybe their rates would be different.
That's exactly right. So we're predicting after they've already made an attempt. So the question is, can we predict, we administered this test in the emergency room, can we predict who makes an attempt move after they leave the hospital? And so that's what we looked at next. And we see that those with a negative D-score, 10% made an attempt over the next 6 months. Those with a positive D-score, about a third made an attempt over the next 6 months. And the IAT score added incrementally to the prediction of who made a reattempt in the next 6 months, above and beyond chart diagnosis, clinician prediction. Clinicians are no better than chance at predicting who's going to make a suicide attempt. I'm a clinician. We're just not good. We're no better than coin toss at predicting which of our patients are going to make an attempt or not. Above and beyond patient prediction, patients are better than chance. We asked them, what's the likelihood you're going to make a suicide attempt in the next 6 months? They were able to predict above chance. And your baseline score on a scale called the Beck scale for suicide ideation. Basically, what was the severity of your ideation at baseline? We put commonly used predictors in the ER and other settings. We put all of those in and then added the IAT score, and it predicted without those in, it predicted after, even after those are already in. So it did incrementally improve prediction with decent, not perfect, sensitivity and specificity. This is one study. We had colleagues in Alberta, Canada. We sent them the test. They did a study that was the same, except that instead of 6-month follow-up, they used 3-month follow-up because it was a dissertation, so they didn't want to wait longer. And they found very similar results. The IAT score added incrementally to the prediction of, they measured self-harm, so it combined self-injury and suicide at follow-up with very similar sensitivity specificity. So we have some indication that this is replicates across samples. The last thing I want to talk about, so we can look at a person's implicit association with or identification with suicide. Ideally, what we want to have is a battery of tests that can tell us about how a person's thinking about suicide or who's most at risk. So another thing we looked at was attentional bias towards suicide-related information. What we think is that if a person's thinking about suicide, if they have suicide on their mind, they will have trouble responding to or disengaging from suicide-related information. And we tested this out using a suicide Stroop task, which is a modification of the well-known Stroop color naming task that you're probably familiar with. And invented by Hans Stroop in 1935. So if you see the word blue and red and yellow and I ask you to name those words, you can name them pretty quickly, not surprisingly. If the word blue appears in red font and I say read this word, the content and the color interfere and you have a tough time responding. What we wondered is, if we give a simple color naming that task to people in the emergency department, some are suicidal, some are not, will people who are thinking about suicide have trouble responding to suicide-related, naming the color of suicide-related words because the content of the word will interfere with their ability to respond. This has been shown, I should say, for combat vets. So this isn't completely novel, that combat veterans are slower to name the color, combat veterans of PTSD are slower to name the color of words like bomb, explosion, and so on. So there's some history in psychology showing that emotionally salient words interfere with a person's ability to respond. So we tested whether this is the case with suicidal people in the ER. So again, you have a laptop, you've got a little red tab, a little yellow, a little blue tab, and we ask you just name the color of the word. You see a fixation cross. You have neutral words like paper, red, blue, suicide. So we say if you're thinking about suicide, it should take you a little bit longer to respond to suicide-related words. There are 48 trials. We have negatively valenced words as well, like stupid, worthless. to see, is this suicide specific, or is it any negatively valenced word? Maybe this is just an effect of depression. Same design as before. We have research assistants with laptops in the ER at Mass General Hospital. And what I'm going to show are interference scores. So how much longer does it take you to respond to negatively valenced words than neutral words? So what extra interference is there for the negatively valenced word? Suicide attempters are in black, non-attempters are in white. There's no real effect for negatively valenced words. Effects in the right direction, but not significant. For suicide-related words, we see huge interference for suicide attempters, and no effect for psychiatrically distressed non-attempters. So a significant difference between these groups. And like before, performance on this test significantly improved suicide attempts above and beyond clinician prediction, patient prediction, chart diagnosis of depression, and so on. Put the same factors in, tested this one as well, and had similar results. So what we're doing now is attempting to replicate these in a study at Children's Hospital Boston. This is completed. The self-injury results replicate exactly as I presented. We see differences for self-injurious and difference across suicide groups. We're looking at the Suicide-IAT now. And we have a website set up now for those who are interested called, the project is called Project Implicit Mental Health. It's at implicitmentalhealth.com. And anyone with access to a computer can go and learn about implicit cognition and also take implicit association tests, the self-injury test, the suicide test, but also tests about eating, alcohol use, stigma about mental illness. Do you think people with mental illness are dangerous versus not? So it's an education website, but also a demonstration website where we are collecting data without any identifying information and pooling these data to see, these are small samples, thinking back to my first slides about epidemiological studies, advancing over those that use 50 people and 100 people and so on. So we've collected data now on about 6,000 people, we have about 6,000 self-injury and suicide IATs, and we have a paper in preparation now showing these are robust effects. We see the same pattern of findings with big difference between self-injurious and non-injurious, suicide attempters and non-attempters, and so on. The next big challenge is, how do we use this information? So we can measure a person's D-score. What do we do with that? Do we go to a psychiatrist in the emergency department and say, hey, this person has a D-score of 0.1? And they say, what does that mean? And how do I combine that? If they're low on every other risk factor, what do we do with that information? How do we synthesize this in a way that best predicts? And so we're just about to start a study in the emergency room at Mass General where we're using our risk index, our IAT, our Stroop, and also an algorithm that looks at a person's medical record to see, can we create a risk calculator, an iPad-based or a tablet-based 15-minute test that can tell us a person's level of risk for subsequent suicidal behavior, combining all that we've learned so far, and how do we give this information to the clinician in a way that helps them better predict and prevent this outcome. We're developing other tests of cognitive processes that we think are related to suicidal behavior, and starting to test out interventions that turn levers on some of these constructs to see, can we break associations with suicide? Can we train people to just let suicidal information go by and not be so engaged with or interfered by it? So I'm going to end there. So overall, what I hope to convey is that suicidal behavior is prevalent and looks pretty consistent cross-nationally. What we need to do moving forward is continue to develop ways of using information that we've collected to better predict and better prevent these outcomes if we're going to make a dent in this problem. We're also learning that suicidal thoughts are transient in nature, triggered by a range of different feelings. I talked about some of the descriptive stuff we've learned so far. I think there's huge potential for increasing real-time measuring of these things. As a field, our best results so far are looking across a year, 6 months, 2 years. We have no idea what predicts imminently, what tells us whether a person's at risk in the next minutes or hours or days. And there, I think we really need real-time monitoring approaches to fill in that gap. And we've developed some behavioral tests of self-injurious and suicidal thoughts. I think we're just scratching the tip of the iceberg. There's a huge room for improvement here, but I think there's a whole new avenue of suicide research and clinical prediction and intervention that could be exploited to help us get better at predicting and preventing this really serious and dangerous problem. I want to end by acknowledging all of those who helped with this work. I'm here as a mediocre figurehead for our lab. I'm fortunate to work with a range of different postdocs and graduate students, including most recently Karthik, who's been working with our group, providing really valuable insight into a lot of these problems. I also want to acknowledge our primary faculty collaborators and our sources of funding, without whom this work would not be possible. Thank you so much for your time and attention, and I look forward to answering any questions you might have.
mentioned that you're trying to use algorithms and things to kind of use the patient history and like that kind of stuff. Why not use a human? Because there's like some things that just get lost in translation, especially unless you have like a Watson type computer that's like as up to date as like a human brain. Like
Right.
you can't do it. So I feel like you need a human to kind of parse that data and like provide that context, because there's cultural context mixing. There's probably other components, familial factors,
Right.
international components missing.
Right, right. Great question. So I think I agree. I think the answer, my own 2 cents, the best solution is going to combine what machine learning algorithms can tell us and what humans can tell us. And we need this interaction. We've been doing it with just humans for a long time, and we're not good at prediction. And what we think is there's a lot of we're not good at combining these risk factors. And I think even when we add up risk factors that we can easily measure, we get better. What we wonder is there information in a person's medical record that it lies dormant and no one ever sees it? I'm thinking about killing myself, and so I'm going to the doctor, a primary care clinician with vague somatic complaints, and I've been there 5 times this month, and I go to the ER, and the ER doctor doesn't know that, and doesn't know that my age and my sex and my ethnicity and my history of mental disorders and my treatment history and my more recent vague somatic complaints all pile up to increase my risk. So what we're proposing to do is to use all available records to generate a risk score or a predicted probability of suicidal behavior under the next, in the next month and the next 6 months, and then give that to the clinician. Not to say, hey, clinician, we figured it out, this person's at risk, but here's the person's probability. You use that information as you think appropriate. You might say, yes, thank you. I can see why you said that, because it is a middle-aged white male or an older white male who's a high-risk group and with a history of it. But I've done a thorough assessment, and I think this is a false positive. Great. So we don't presume to think we're going to have the answer, but we'll be able to tell clinicians who to focus on and who is probably at really low risk and don't do such a thorough screening on. So we think of it as a sort of clinician decision support tool or a screening support tool rather than the answer.
Thank you.
Yeah, thank you. Great question.
So, hi, here in the front.
Oh,
hey,
sorry.
Hi, Kevin Slavin, hi.
God is it?
No, definitely not. Whatever the opposite is. In a conversation with an actuary from AIG, what he was saying is that they see a very notable increase over the last couple of years among middle-aged men in the United States. Mm-hmm. And I was wondering whether you see that, or if you have any thoughts about what causes those types of fluctuations in any given population. Yeah.
It's a great question. I tend to, so if you look across, so how do I say this? If you read the New York Times, middle-aged black women have a 25% increase in the past year. But if you look at the past 20 years, the lines look like, the suicide death rate, if you look at 1900 and 2000, it's the same. And it goes like this a little bit. As you break up smaller and smaller groups, your cell sizes get smaller and smaller, and you see a lot more variability. We do see some longer-term trends. Suicide death among older men has been dropping pretty steadily. So I think there's something there. So I look at the time trend and see what period are we talking about. So I tend to put less stock in the 1-2 year trends and more in the longer term trends. We did a study on suicide in New York City police officers in the mid-90s. There was an epidemic. I think there were, it was 15 suicides. And I mean, to be little, any suicide is tragic, but we're talking about small sample, low base rate behavior. We looked across a 20 or 30 year period, and the rate looks like this, and just 1 year it happened to pop all the way up, next year it came right back down again. And so a lot of attention was given to the problem, as it should be, but it wasn't the epidemic that everyone said. It was just, with the low base rate, the rates are going to bounce around a lot. So a long-winded way of saying, I would take a little bit longer view, but I think those trends can be important. I mean, they are going up and down. There may be forces that are pushing up and down. Maybe it's chance, but there could be something real, pushing in one direction or the other. But I'd be cautious in over-interpreting short periods of time. Hi, yes.
Hi, quick question and then a real question. First, have you ever seen a correlation between native language and risk behavior? And then the real question is, so I'm sure I'm not the first person to feel like Twitter is an excellent source of trying to detect at-risk behaviors in the wild, like you were saying.
Right.
What do you feel like the both practical and ethical considerations would be for doing that type of study?
Right. I'm not quite following the native language. Do you mean if a person's in a context where they're speaking their native language, or do you mean across?
Work hypothesis that like your language, the structure of your language shapes your.
Oh, I see.
That's sort of
I see. Interesting. No, there are big and pretty consistent geographic differences in the rate of suicide death, with lower rates in South America and higher rates in Eastern Europe and so on. And there hasn't been a good explanation of why that is. I don't know that anybody's looked at language as an explanation. It'd be interesting to look at. So I'm glad that wasn't the real question, because I don't have a good answer to it. The Twitter one, yeah, there are a lot of folks now, and we are sort of starting to push into this arena as well, saying how might we, with Karthik's expertise, how might we use social media to hone our signal, how to try to be a little bit stronger. I think it's not going to be the answer, because most people are not on Twitter, and we're going to have a lot of false positives. The Patriots just lost, I'm going to go kill myself. Really, it's there's nothing there. But it could provide some kind of signal, a piece to a puzzle that could be added to everything else. The trick is, how do you identify those signals in a useful and reliable way? And then there's the ethical concerns. And I don't know if you've seen this. The Samaritan's Hotline has this Samaritan's Radar app that measures if you get the app, measures your Twitter posts. And if you tweet concerning terms, your friends will be alerted so they can contact you and get in touch. Sounds great, huge backlash, and they just pulled the app because people were saying, this is fodder for bullies who, I'm a kid who's bullied, I tweet that I want to kill myself, now my bully sees that and turns that against me and so on. So I think the science isn't quite, there's lots of claims, as often happens, there's lots of claims get made about how useful this is or how useful it's going to be. In my read, the science isn't quite there yet, but I think there is the potential for something that again, could add a piece to a puzzle. I think any one of these approaches, using self-report, using a behavioral test, using electronic medical records, using real-time data, using Twitter data, I think they're all pieces to the puzzle that we're going to need to combine and triangulate to track, in place and time, who's at risk. Right now, we're very high, 30,000 feet, pretty crude analysis of which groups are at high risk, but we're not measuring the risk factors or in any kind of real-time dynamic way, and Twitter may help us be able to do that. Yes?
Hello.
Hi.
So this is a related two-part question. So,
Only true, false. I'm taking it.
so similar with the Twitter thing, where someone saying I want to kill myself is could be an indicator. Another big area of research, just on the side is tracking elderly in their homes to monitor mental decline.
Right.
Do you think that there's behavior patterns within the home specifically that could be isolated that could indicate suicidal behavior or depressed behavior, something that could lead up to an incident? And how would you monitor something like that? Do you think a camera versus passive sensing is a good idea, or do you think violation of the privacy would affect the person's behavior and kind of give false information?
Yeah, great question, and I think largely untapped area to my knowledge. I think the camera thing would be a concern, and we went to our IRB to say we're trying to think of how do we capture episodes of self-injury, and we have you push the button, but even pushing the button, people will do it within at best a 5-minute window. So what about having cameras in the house? And so we went to IRB and said we want to have cameras in the houses of these adolescent girls who are cutting themselves, and they're cutting themselves in the bathroom, in the bedroom. And they said, so you want to put cameras in teenage girls' bathroom? Are you sure? We said, yeah. As you say it out loud, it's probably not a good idea, and isn't going to make it through the IRB. I think the same is true with putting cameras in people's houses. There's concerns about invasion of privacy and so on. But I think I've seen things on smart houses that measure how many steps a person's taking and so on, or in certain places in the house can scan their body posture or their voice. I think there could certainly be some signals there, whether it's a slowing down of motor behavior or increase in agitated behavior, that could be signals of distress or that can help us predict this behavior. I think getting there, though, is going to be easier said than done, but I think there's certainly value to it.
Thank you.
Thank you.
Thanks, Karthik. Thank you for coming over and sharing your wealth of knowledge.
Thanks for having me.
my question is goes back to one of your first points about the overall incidence. I was curious about New Zealand. Were you able to, a two-part question, A, were you able to differentiate between the Maori population and the Caucasian population? No?
No.
Okay, and then why would you say is the U.S. apparently the action-oriented leaders of the world of suicides? Why is that?
Right, it's a great question. So why, for those who might not have heard, why are rates of suicide or non-lethal suicidal behavior so high in the U.S.? I should note, in clarification, the U.S. is sort of middle of the pack in rates of suicide death, but we're higher up in not just suicidal behavior, non-lethal suicidal behavior, but in mental disorders pretty much across the board. And so that question comes up, why is that? And I don't know the answer. A large part of it could be lack of stigma and willingness to report. I think in the U.S. we've become very open about this I think we still have a long way to go, to be clear, but we've become more open in terms of discussing mental illness, discussing treatment of mental illness. We've got commercials with bouncing pills on television and so on. And so it's not as taboo as it still is in other parts of the world to say, I'm depressed, I have a problem with alcohol, I've thought about killing myself. And so I think that's one interpretation is stigma might be lower, willingness to report is higher, and so we see differences in self-reported rate of non-lethal suicidal behaviors. But I don't know for sure based on on the data that we have.
Hello, I come from Finland and we score pretty high on on this. So I would like to ask, have you been studying correlation between diet and food supplements and suicidal behavior?
We have not looked at diet. There is a new study going on at Medical University of South Carolina called the BRAVO study, which is a study of omega-3 fatty acids. It's a very large-scale clinical trial with veterans to test whether omega-3 fatty acids decrease suicide risk. There are correlations between omega-3 fatty acid intake, cross-nationally, and depression and suicide, death, and so on. And so I think there's definitely a signal there by my read. And hopefully this large-scale trial will tell us, it's a placebo-controlled trial where half people are getting juice boxes with omega-3s and half are getting juice boxes that look like this, the same juice box, but they don't have omega-3s in it. And we'll see whether there is something there. Diet more generally, I don't know. My own, with limited data, my 2 cents, I think there could be a lot there in terms of diet, sleep, exercise, these sort of low-hanging fruit, so to speak, interventions that aren't widely used. We think about medication, we think about psychotherapy. We've got signals suggesting diet, supplements, exercise, sleep hygiene interventions can have a big impact. So I think packaging these could be a really somewhat easy, natural way to go. Yeah.
On your last slide, you said that you're starting to look at interventions. I'm curious whether you can give us a little bit of a sneak preview of the types of things you're looking at.
Sure. So our first forays are trying to break some of the sort of mental associations we found. So working backwards, on the Stroop task shows this interference or maybe trouble disengaging from suicide-related information. So we followed it up with a randomized clinical trial, small-scale trial, that trained people to disengage from suicide-related words using something called a probe discrimination task, or modified version of a probe discrimination task. You see 2 words appear on the screen, they'll disappear. One will be suicide, one will be chair, and then behind one of them is an E or an F. And you've got to indicate whether it's an E or an F. And when we do this, what we find is that people who are suicidal respond more quickly when the letter follows the suicide-related word. Because they see 2 words, their eye goes towards suicide. And so if the E or the F is there, they respond quickly. If it's behind the other word, they respond more slowly because they have trouble disengaging from the suicide-related word. Turning this into an intervention, put the E or the F 100% of the time or 95% of the time behind the non-suicide word. Over time, we can train a person to disengage from suicide-related information. People have shown with anxiety disorders, this can decrease anxiety disorders by training people to not attend to threatening information and so on. It's worked with anxiety. There's some indication it can work with mood. We tried to train people in 2 trials to disengage from suicide-related information and it had no impact. More recently, a postdoc in our lab, Joe Franklin, is using an evaluative conditioning intervention to try and break the positive association between self-injury and good, or self-injury and me, to see if we train people to do this over time, can it decrease their evaluation of self-injury and engagement in self-injury. So essentially taking some of the associations we've seen and trying to break them.
So it's sort of, you want people to see themselves as a non-suicidal person, or
Yes.
not associate themselves with...
Self-injury is bad.
Yeah.
Self-injury is not like me. Positive things are like me. Can we condition a person over hundreds, thousands of trials on a computer or on a smartphone to change their mental associations about suicide and self-injury? The way I think about it, if I'm somebody who thinks when I get distressed, I cut, versus, so cutting is like me. If we can break that, maybe I'll think when I get distressed, I'll exercise or I'll do something else that will make that behavior less favorable, less accessible, less identified with.
Are you aware of any apps that start doing things like this? And
I am.
yeah.
We have some some being tested in our lab right now. So some early positive results that we're attempting to replicate, and if they do replicate, we will, hopefully publish the results and share them widely and try and turn the lever on these problems.
I'm sorry to put us to a stop, but let's cut this down time. We'll thank Matt, Nock, and then some of you can have a few more minutes to come up and ask questions.
Great.
Afterwards.
Thank you. Thank you. Thanks.